So it's my pleasure to introduce Dr. Barak Gaster to speak at Medicine Grand Rounds this morning. Dr. Gaster is a professor of medicine in the Division of General Internal Medicine and has previously served as acting medical director at the UW General Internal Medical Center at Roosevelt. He also serves as chair of the UW Medicine Advanced Care Planning Committee. Dr. Gaster obtained his medical degree from the University of California, San Francisco, followed by completion of house staff training and chief medical residency here at the University of Washington. Dr. Gaster's clinical practice is based at the UW General Internal Medicine Center at Roosevelt, where he specializes in outpatient primary care. He has previously developed research and curriculum related to complementary and alternative medicine, and, more relevant to this discussion, has been investigating tools to help primary care providers diagnose dementia earlier and to guide patients with dementia and their families through this diagnosis. More recently, he's been developing advanced directives for patients with dementia, and some of this work was published in JAMA and was recently highlighted in the New York Times. Please join me in welcoming Dr. Gaster as he presents Dementia Now, Taking Action to Meet the Challenges We Face.
So thank you so much for that kind introduction, and thank you all for being here. Let me start telling you a little bit more about me, in that it's a little bit of a funny story, in that somehow over the years I find myself falling into working on some of the hardest issues that we face in medicine. And just like he was just saying, I started out talking about trying to figure out what is the evidence behind herbal medicine and other dietary supplements, a hard issue. Figuring out how to make opioids safer, worked on that for many years. And then the very, very tricky sort of question of how do we talk to men about the pros and cons of prostate cancer screening. And it was about 4 years ago that I realized that maybe the most difficult problem for us to face and for our patients to face is dementia. And that there might be no other problem that is right in front of us that we get stuck on the most. And so the question really is, how do we meet this challenge? How do we meet the challenge of dementia? So just quickly, a little bit of statistics. I mean, this is a big problem. Over 5 million people in the United States have dementia. Among people over age 65, it's about 10% of the population. Over age 85, it's more than 30% of the population. But really, the problem that we have now is nothing compared to the problem that we're going to be having soon, which is that the numbers are expected to increase by 40% in the next 10 years, and they're going to triple in the next 20 years. And so every time I say that, it is just such a shocking statistic. Like, how can it possibly be that this is going to triple in the next 20 years? And it's just really like, what is up? How can that possibly be? And there's really two forces at play. So number one, people are just living longer. And so we're doing a better job of treating people's MIs and curing them of their cancer. People are quitting smoking. Many more people are living into their 80s and 90s than ever before. And then there's just this very strange demographic situation with the baby boom. And so here's a graph showing the number of births in the United States in the 20 years after World War II, where you can just see that live births in the United States really just shot way up and then came down. And if you sort of combine that graph with this graph showing the age at which people develop dementia, you can see that it really is an exponential rise that starts right around age 70. And so you put those two graphs together, and you end up with this graph, which shows that where this cohort is now, where this baby boom bubble is now, is most of them are in their 50s and 60s, but the very leading edge of that graph is right there reaching that critical age 70 when people are really at risk for dementia. And then if we follow that cohort through 10 years from now, they're moving more and more into that zone. And then it's like 15 years from now, boom, that's where we start seeing this tripling of the population of people with dementia. And so that's, what has somewhat sort of tongue-in-cheekly been called the silver tsunami, which is that it is not too long from now that whatever we perceive right now as a big problem of dementia, especially in the medical system, is going to really exponentially rise. And so that's why this really is, in many ways, the #1 disease challenge that we face. So, how can we do better? What must we do? And, absolutely, I can say that 20 years ago when I was, finishing residency, finishing medical school, the amount of training that I got in dementia was pretty close to zero. And which means that the vast majority of physicians in practice today, many of the people in this room have really never really been trained on how do you identify dementia and how do you help to manage it. But we've got to stop ignoring it. We need to call it out. And I think just developing that skill of talking to patients and families about it is just so critical. Just bring this disease out of the shadows. We've got to do better. And so we've got to start talking about what is the value of an earlier diagnosis, because I think this is the #1 obstacle that we start running into of, gee, this is such a hard conversation to have. This is such a difficult diagnosis to make. Why should we be doing it? What do we need to be doing? And the reality is that right now, so many people with dementia are simply getting bad care. That they're cycling through our clinics and our emergency rooms and our hospitals without, this big elephant in the room being called out. One of their major organs is degenerating, and we're not taking that into account as we plan their medical care. Their preventive care should be adjusted, take into account their dementia diagnosis, their communication with them and their families, just all kinds of medical decision making that we do, really needs to have dementia as one of the organizing principles of their care. Just getting it on a problem list can do so much to help to shape the care more appropriately. And just getting patients' families more involved early. And because what tends to happen is that people will stumble into pretty severe stages of dementia without a family even being sort of brought into the loop to understand what's going on. The amount of anger and confusion and tension that can build up in a family because everybody's like, why is Dad acting so strangely? And there's certainly sort of whisperings and wonderings, but to not have that family brought into the loop, into the medical conversation, is really a huge missed opportunity. And I have done a fair amount of work lately on advanced care planning, and really probably the most important part of advanced care planning is identifying a durable power of attorney. And many people might say, gee, why do I need a durable power of attorney? Isn't it just going to be my spouse? That's sort of the legal default. Everything is fine, right? And yet, the issue with dementia is this is a 5 to 10 to 15 to 20-year diagnosis. And so the idea that whoever would be your sort of automatic default surrogate decision maker is still going to be there as an adequate durable power of attorney for you in 5 or 10 or 15 years is a really questionable proposition. And so having that durable power of attorney form in which not only do you identify who your first up would be, but who the second and third backup person to that would be is incredibly important when you're talking about dementia. And then just there are all kinds of safety issues that right now we're not engaging with because we're not making this diagnosis. So things like how do you safely and appropriately retire from driving, identifying bad drug choices that can get made that we'll talk about, and just really the incredible risk of preventing financial abuse. So as people slowly drift into dementia and losing decision-making capacity, we do an okay job some of the time identifying the surrogate decision maker for health decisions, but we tend to overlook or not engage with the issue of financial decisions, and that is the issue that puts so many elder people at risk. So really, engaging with this disease, making an earlier diagnosis is exactly what we need to do in order to start doing appropriate care planning, and really just bringing this disease out of the shadows, like I said, to make it something that we can talk about and accept and have it be less of a eating away inside uncertainty and something that is more acceptable and real. So if we're going to start talking about how to make an earlier diagnosis of dementia, we've got to talk about the MoCA. The Montreal Cognitive Assessment is the most useful tool available to evaluating concerns about memory. It is more sensitive than the mini-mental status exam, and don't even get me started of how the mini-mental status exam somehow turned into this for-profit tool that you have to pay to use. But you know, the MoCA is really easy to learn. It takes 10 minutes. It can be done in any doctor's office, and you know, combined with the story from the patient and the story from the family, really does have excellent, maybe even better than 95 sensitivity and specificity for identifying dementia. So what about the mini-cog? So, I mean, the mini-cog was developed here at the University of Washington and is in very wide use as well. Problem with the mini-cog, it's true that it's faster, but its sensitivity for identifying early stage cognitive impairment is much less than the MoCA. And so when you're talking about what's the best way to evaluate early stage memory concerns, definitely the MoCA is much better than the mini-cog. And so, you know, it raises a great question. So, you know, we're talking about how important it is to make this early diagnosis. We should be making an earlier diagnosis. We should be identifying this big pool of unrecognized dementia in our midst. And so a really contentious and important issue to consider is, should we be screening everyone for dementia? You know, should this be an absolute regular part of everybody's medical care in the same way that they get a mammogram and a colonoscopy? Should they get a mini-cog? And you know, the question there is a much bigger, deeper question than should we be, you know, more attentive to identifying it, because anytime you're going to talk about big, giant, mass population screening, it really raises a question of, could we be doing more harm than good from that? And it's really important to ground ourselves in solid evidence to make a decision like that. And the reality is that the data is very fuzzy. You know, that every evidence-based guideline absolutely says, no, we should not be doing routine screening for dementia. You know, the United States Preventive Task Force published this 5 years ago, and then a Lancet Commission just 4 months ago confirmed that this is where the current evidence is. So this is a big, giant global commission that the Lancet brought together, that Eric Larson was very involved in, that really confirmed again that the evidence just is not there for doing mass screening. And just really trying to wrap our brains around, why is that? What is up with that? Because I was just saying that there is definitely benefit from more detection and earlier diagnosis. And yet the idea of casting a wide net of every single person who walks into a doctor's office also raises considerable risk of harm. In risk of false positives, more uncertainty of what happens when you get a borderline result, more stress, more system overload. And I would just argue that right now, there is this big sea of dementia that's like right in front of us that we don't need to go screening for, that we're doing a pretty bad job of engaging with. And so before we go casting out this wide net and gathering even more cases of dementia that we're not doing a good job in, we really should be beginning right now to figure out how to engage with a dementia diagnosis earlier and better. And you know, let's wait and see what happens with mass screening. You know, but I really can't emphasize enough that we may not be ready for true screening, but that does not mean that it's okay to ignore memory and cognition concerns. You know, that it is absolutely crucial that we develop a much higher index of suspicion for dementia and really prepare ourselves and train ourselves to do a dedicated workup when concerns arise. And, you know, this is not happening now. So right now, you know, patients will say, I'm worried about my memory, or we'll hear from a family member that I'm worried about my loved one's memory. And it is incredibly easy to just sort of, you know, quietly sort of reassure somebody, and oh, that's normal, that's aging, don't worry about it. And that's what we need to change. And that's what we need to change first. And maybe down the road, we'll get to sort of population-based screening. It is, we gotta work it up. One of the main sticking points that comes up when the issue of mass screening comes up is, do we have a disease-modifying drug for dementia? And the answer is no. And not only do we not have one now, but the pipeline has been looking rather bleak lately. So, several large pharmaceutical groups have, announced in the past year or two that, they've had really disappointing results from early stage trials. And, Pfizer has even sort of said, we're not going to work on this right now in terms of finding disease modifying agent. So it's not that there aren't lots of people working on it and that there are startups going on, but we do not have an imminently in any way exciting disease modifying agent for dementia. We do have, there are drugs, there are cholinesterase inhibitors, but a huge systematic review published just 2 months ago in the Annals confirmed that these drugs they barely work. And what I would say is that in some patients they may result in small improvements in cognition. They might slow the loss of cognitive function a little bit, but it's often really hard to tell. But the key point is that they do not change the course of the disease. They do not work for early stage memory loss. And so, that would be one of the main strong points of should we be screening everybody. If we had a disease modifying agent that you think would work better, the sooner that it's instituted. But that's not how these drugs work. When they have been tested in mild cognitive impairment, they haven't worked. And they don't help with severe dementia either. And so another key point is that, often people get put on these drugs and just are left on them. And as their dementia gets worse and worse and quite severe, and you're dealing with polypharmacy issues, that drug is still there, and it's also definitely not been shown to be effective in treating severe dementia. The most widely used of the cholinesterase inhibitors is Donepezil or Aricept, and a really beautiful study that was done in Indiana, published last year. Really in a very pragmatic primary care setting, let's try Donepezil and see what happens. And 40% of people had stopped it within 4 months, mainly due to side effects. They compared it to other more expensive agents such as rivastigmine and galantamine. They were equally effective-ish. They equally were stopped due to side effects. And, the side effects are not, horribly alarming, but there are many of them. So it's headache, sleep disruption, nightmares, dizziness, and diarrhea. Most tolerated okay, though, and so it's not a wrong thing to offer Aricept or Donepezil. But, just be aware that these drugs are not quite what they were cracked up to be when they were first FDA approved many years ago. So what about diet and exercise? Again, just 2 months ago in the Annals, a huge systematic review by the AHRQ was published, which reviewed dozens of studies. A few were slightly suggestive, but almost all of them were negative. And yes, there is a signal that exercise might be promising. The most intriguing of those trials was the finger study that was done in Finland and published in 2015, in which there was a small effect over the course of 2 years in people randomized to a very, very intensive program of diet counseling and exercise, in which there was a small benefit in cognitive function over the course of 2 years. So it's important to emphasize that exercise is good, and that that we all should be exercising, and that there is even a reasonable chance that exercise might help a little bit in terms of cognitive function. But it's hard to really sort of hang your hat on this and say this is a strong evidence-based recommendation. But a tremendous amount of research is still going on in this area, and so fingers crossed. but really maybe the most difficult conversation to have as you are making this diagnosis of dementia is the whole question of driving. Driving is so central to independence in modern U.S. culture that the idea of somebody no longer having that independence and no longer being able to drive really kind of strikes at the heart of a lot of people. And so I really would recommend a careful stepwise approach in beginning the conversation talking about driving with people with that diagnosis of dementia. And, on one hand, you may initially say, oh my God, as soon as somebody has that diagnosis, no way should they be driving. How is that possibly safe? And, you think of your own kids on the road and like, the reality is that the majority of people who have early stage memory loss are actually still safe drivers. That there was good data in the Seattle Times about 4 months ago or so where they looked at the rate of fatal crashes in different age groups, and that over 85 group that you'd think would be sort of really scary is actually sort of a much safer age group than the 16 to 20-year-olds who are I signed my daughter up for driver's ed just last week, and it is this is an important issue to bring up and to start talking about, but we need to be balancing, safety of the patient, safety in society with the independence of the patient. And so just introducing the topic early and gently in a non-threatening way, saying, I'm concerned about this, we need to start planning for this, really suggesting safety measures that you can institute far before you're actually taking somebody's keys away, such as, you really shouldn't be driving at night, shouldn't be driving in unfamiliar routes, and really let's start talking about what are other ways that you could get around to maintain that independence. There is on-the-road voluntary testing that you can say, I believe you can drive, and, you believe you can drive. Let's show everybody that you can still drive. And, this is not an easy sell. This is something that people have to sort of voluntarily and actively engage in. The Alzheimer's Association website and the AAA have websites where you can find driving tests like this. They cost about $300. They're generally not covered by insurance, but it's definitely something that you can get somebody to do, especially with a family's sort of urging and encouragement. And then in the state of Washington, there is a relatively easy form that you can very easily find online to report a driver who you think may be unsafe to the Department of Licensing. And when this is definitely not an anonymous report, your name will be there. The patient will be aware that you are the one who reported them. And what the Department of Licensing does is just requires frequent testing for license renewal. And even though this sounds like, oh, it's easy, that's a good fix, and you can try to communicate to the patient that you think that they can do it, you think that they can pass the test, you just want to sort of have them show that they can. I have had more than one situation with patients where this has been almost kind of a deal breaker, and it was like, I'm never going to come see you again if you do this. And so, but there are times when you still need to do it, but just going into it with the awareness that you are really striking at somebody's sort of sense of independence in a major way. But there are times when you got to do it, and but there I would also say that there are times when somebody will lose their license and they're going to still keep driving. So taking somebody's license away does not mean that they're going to stop driving. So there is like that final kind of nuclear option of taking somebody's keys away or changing the ignition on the car. That's there. That's just sort of part of this stepwise approach. And so starting by talking about the beginning the conversation early and starting the planning, considering the voluntary testing, reporting somebody to the Department of Licensing and then taking their keys away, is the sort of progression of risk management that we all should be doing. That is really one of the key benefits of making this diagnosis earlier and talking about it. Another incredibly important key resource that we have here in the state of Washington, and that really is available to anyone anywhere, is a safety kit for families that the Dementia Action Collaborative has put together that Christopher Rhodes from our very own Memory Brain Wellness Center has been helping to lead the way on, which is an incredibly useful kit that has tips for home safety, fall prevention, preventing elder abuse, financial exploitation, easily available for free on the web. Highly recommend it. Another incredibly important resource that we have here in Seattle, which is really a beacon of innovation across the country, is an organization called Momentia Seattle, which again, sort of one of our very own Memory Brain Wellness Center, UW, people, Mary Grace Becker has been very involved in helping get launched, which is really all about the idea that a diagnosis of dementia is not sort of the end of the world, that people have many years of good quality of life left when they are diagnosed with early stage memory loss, and that life does not end, and that that there is still plenty of living and fun to be had, and Momentia Seattle is all about that, this is also really together with that, people should be exercising, and isn't that going to help to preserve their cognitive function? It just absolutely makes sense that the more active and interactive and sort of getting out and doing stuff, the better off people are, and the more likely they are to remain independent and remain sharp for a longer time. So these are group activities to go out and do, all of the great fun stuff that is listed there. All right, so now let's talk about, so I said driving is the hardest thing to talk about in the very early stages of a dementia diagnosis. But it's really the behavioral problems that come up as dementia progresses that is, maybe the most sort of horrifying, difficult part of dementia care. And here we're talking about agitation, we're talking about paranoia, yelling, maybe even sort of physical violence. That about 80% of people with dementia will face at some point. Key point is that it is often self-limited. So it's not like once it sort of comes up, that's going to be a fixed part of somebody's care forever. It comes up at some point for most patients, but not all. And it comes on for, hopefully often a shortish amount of time. But when it does, it's horrifying. It's terrible to see the person who you loved and who was the kindest, sweetest person is all of a sudden not kind and sweet anymore. And so here's where the inappropriate medication prescribing comes in, and here's where making that diagnosis earlier can help to avoid sort of medication misadventures. So oxybutynin and Ambien are incredibly commonly used drugs in the over age 85 crowd, and the degree to which they can impair cognitive function and make behavioral problems worse in patients with dementia is high. And then the other real kind of counterintuitive clinical pearl is benzodiazepines. Generally, when faced with severe agitation, benzodiazepines are our friend. This is the sort of relatively safe, incredibly effective anti-anxiety medication that we use all the time for agitation. And it is just a real kind of sort of weird counterintuitive quirk that benzodiazepines can often make behavioral problems in dementia much worse. And so you got to be really, really cautious with that. So what can you do? I mean, there is, this giant body of work of non-pharmacological approaches that people can take that really have been shown to reduce the behavioral problems with dementia. Probably the best book to recommend to people is The 36-Hour Day, that has gone through many, many iterations of improvement. The problem is that it's a big, thick book, and that just kind of handing it to somebody and saying, read this and go and do doesn't often work. There's going to be some very engaged families who will do that, but this is really where the value of social workers and care coordinators comes in, because we as physicians are not going to be able to take the 1 to 2 to 3 to 4 hours over multiple encounters to really help a family to incorporate these non-pharmacological approaches. The Alzheimer's Association is really pivoting in a major way of trying to get better at helping families with this, and so I would definitely check their website for referral options. But this is really, I think, one of the most sort of important future innovations that our society needs to make to help to provide better social work care in the home, to help families to institute non-pharmacological approaches to behavioral problems. And when I say home, I'm also talking about adult family homes, because more and more, when patients with dementia reach the level of behavioral problems, they're often not in the home anymore, and they're not in a skilled nursing facility, but they are in these, what can be very, very effective and good small adult family homes, who also need help with this as well. But sometimes those non-pharmacological approaches don't work, and you really are left with these really sort of anguishing, horrible outbursts of behavioral problems, and that's where antipsychotics play a huge role. They work. Quetiapine is probably the safest and the most effective. A trial of quetiapine is absolutely reasonable. The key, the major pitfall that happens, though, is that a patient will be put on quetiapine and just left on it, because it's like, oh, we put that on, it helped, and good grief, like how can we possibly sort of risk going back to that horrible state we were in? Better to just leave this patient on that drug forever. But like I said before, these behavioral problems are often self-limited. They do get better after 3 or 6 or 12 months. And so it's a major harm to just put somebody on quetiapine and leave them on quetiapine forever. And so it's really, really important to have this be a scheduled trial for, say, 3 months or 6 months or 9 months or 12 months, with the idea that if you don't schedule it, it's just going to kind of keep going. That the inertia of the medication list we've all experienced. Once a patient is put on a drug, the inertia just keep them on it is just overwhelming. And so really it's, in the same way that we put somebody on warfarin for 6 months, it should be we put somebody on quetiapine for 6 months, and then we're going to try tapering it off at that point. And it may be that behavioral problems come back when we do so, and that, again, that non-pharmacological approaches don't work. And so we may need to extend that course of quetiapine, but this should not be a put somebody on it and leave it on it. And you might ask why, and it's on one hand, the reason why is that Seroquel does have this black box warning. It has been shown to increase the risk of MI. But I would really say that the much more compelling potential harm from quetiapine is really over-sedation. That they are incredibly effective and they work, but they really can worsen cognition. And you can end up in these kind of crazy polypharmacy situations where, out of kind of the sense of panic, people were put on not just quetiapine, but, oh, let's try an SSRI, and oh, let's try valproic acid, let's put somebody back on Donepezil. And so people can end up on 5 or 6 drugs to treat behavioral problems long after they need them, and the possible side effects of all those drugs and the possible sort of over sedation and worsening of cognition is not right. And so incredibly useful, but again, use in a limited way with caution. By far the most important thing to know about the different types of dementia is Lewy body dementia, which has its pretty marked identifiable hallmark of visual hallucinations, which again you might think, oh, antipsychotic. In the same way, sort of agitation, benzodiazepine, visual hallucination, antipsychotic, sort of intuitive sense. And yet, with Lewy body dementia, putting a patient on antipsychotic can have absolutely devastating, potentially permanent side effects of Parkinsonism. And so, you want to think of quetiapine as your friend when non-pharmacological approaches to behavioral problems crop up, but an absolutely hard stop has to be Lewy body dementia, a patient who has visual hallucinations together with their dementia. All right, so now let's talk about maybe when I talk about the benefits of the diagnosis and what is why is this important and what does it mean. Driving is important and behavioral problems are important, financial abuse is important, but really it's the whole conversation about advanced care planning that is really at the heart of making this diagnosis, because just aligning the care that a patient gets with the care that they would have wanted is just at the very core of good medicine. And so that brings up the question of advanced directives. I can tell you I've been very interested in advanced care planning and advanced directives from the primary care point of view for many years. And I can tell you what a shocker it was the first time, maybe 8 years ago or 10 years ago, that I actually read the standard advanced directives that we give out to people. Especially in a situation like dementia, where I was like, oh, patient has an advanced directive, let's use it, let's go and see what it says. And the odd thing about advanced directives is that they have really taken on this very, very legalistic perspective, which is, it was a really, really fascinating editorial that was in the New England Journal about 6 or 9 months ago that had the great title of, let's de-legalize advanced directives. That right now, advanced directives have become a document that's written by lawyers, that is sort of, you need a lawyer to feel like you filled it out. It gets put away and locked up in your security deposit box. Nobody is really sure what it says, and your doctor definitely doesn't know what it says. And it pertains to these very, very rare situations that, it's true, do kind of rise to this level of the Supreme Court because they're so difficult, but they're very rare, such as when somebody is in a permanent coma or a persistent vegetative state. Yet the #1 cause of losing decision-making capacity is dementia. And it's not just for the last few weeks of somebody's life, but it's for the last 5 or 6 or 8 years of somebody's life. And so, why shouldn't we have an advanced directive that addresses dementia, especially since a very large number of people have very clear ideas of what they would want if they were to develop advancing dementia. And so I'm always kind of curious to ask a crowd, how many people here have a very clear idea what they would want for their own medical care if they developed dementia? So this is a very, very common problem. But dementia is tricky, so it's not easy to figure out how do you develop an advanced directive for dementia, in that the quality of life gradually decreases along the course of dementia from mild to moderate to severe stages, and most people would want different options to choose from, different goals for their medical care along these various stages. And so this is the directive that I developed along with the help of many people. Randy Curtis was probably the most influential person in helping to shape the way this directive currently works, which presents a brief description of what mild, moderate, and severe dementia is like, and then gives people the same 4 options to choose from for each of those 3 stages. You know, we set up a website, dementiadirective.org, to download this directive for free. You know, since we published it in JAMA and got covered in the New York Times and National Public Radio, more than 50,000 people have accessed this directive so far, and it's really continuing to go strong with over 100 downloads per day. You know, but as you can imagine, with that kind of national attention, I've been getting lots and lots and lots of emails. People saying, you know, really moving things, like my mom had Alzheimer's, she suffered for 8 years without being able to speak or understand. Having had this document would have helped our family so much. I had to fly blind with my mom's dementia. I don't want the same thing to happen to my kids. I gave a copy of it to all my friends. Really, everyone should have it. I've worked for many years with people with dementia. Your document distills the most important issues about it. It's simple and easy to use. Thank you. And so I have to tell you that as I was beginning to develop this, my initial thought was, wouldn't the best time to bring a document like this out be at that very earliest stage of memory loss, like right as you're making that diagnosis, where you're, you know, pretty sure that somebody is going to need that directive? Wouldn't that be the best time to have somebody fill it out? My experience has been pretty interesting in that when I bring this out to somebody at that very earliest detectable cognitive impairment stage, it is already almost too late for somebody to really sort of wrap their head around what this means, in that they're still absolutely sort of mentally competent to make decisions for themselves. And if you were to say, you know, do you want chocolate, vanilla, or strawberry ice cream, like absolutely they can make that decision, and there's no problem. But when you say, let's imagine a mental state of yourself sort of 5 or 10 years from now, where your cognitive impairment is going to be more severe, what flavor of ice cream do you think you would want if this were to happen in that stage, or that were to happen in that stage? And it really, people sort of they say that they're grateful, and they say that they will think about it, and they will come back and they'll fill the document out. But there really that is already such a mental leap for somebody that they really are almost physically unable to do it. And so my realization has been that this really should be something that everybody fills out when they reach age 65 or 70 as part of their general advanced care planning, you know, filling out a standard advanced care planning document in case they're in a persistent vegetative state, but really most importantly, like I said before, filling out a durable power of attorney form. And you know, everyone should have access to this document, and I think, you know, my experience has been that a very large number of people want to have that document to fill out. You know, but aside from that sort of advanced directive issue, you know, there's just the much more crucial aspect of advanced care planning for dementia in general, that once people have reached the moderate stage and so have lost the ability to make medical decisions for themselves, you know, gently starting to bring up advanced care planning with the family to talk about what their loved ones would have wanted, broached in a gentle, kind, and empathic way, really, you know, emphasizing at some point we might want to consider the goals of care to be comfort-oriented care only, with a real emphasis on the caring aspect of comfort care. You know, that, you know, I think so many people have a misconception that comfort care is sort of withdrawing care and not giving care, and just like emphasizing that comfort care is the exact opposite of that, that there is a tremendous amount of caring that happens with comfort care. You know, this is the point at which filling out a POLST form is absolutely crucial. You know, would somebody still want to be sort of, you know, chest pounded on, resuscitated. And this is a process, it's hard, but studies show that it's what patients say they would want us to do. So the group in Boston, Velades, has done a beautiful job where they present videos of moderate and severe dementia to people who are, perfectly do not have any signs of dementia, and say, if you were in this stage, what would you want for your medical care? And vast majority say, oh my goodness, I want to be kept comfortable. I don't want to be kept alive longer. So I mean, this is a really, really difficult issue for physicians and families to grapple with. But it's what our patients would want us to do, is to have that gentle, important conversation about what would your loved one want. Again, here at our very own UW, a group wrote this beautiful review on palliative care for dementia. So Susan Merrill, Sean Demers, and Elizabeth Vig can't recommend this review highly enough. Just talking about the conversation of palliative care, when do you think it would be that your loved one would have wanted to turn to comfort as a goal rather than living for longer? Talking about the stress and potential harms of frequent trips to the ER, and there's just such a gap between when the goal is comfort care only for dementia, but when people are still many years left before their Medicare hospice benefit will kick in. And we can talk about that in a second. But so in terms of how do you sort of tailor the care for somebody with dementia as things reach the severe stage, it's the somewhat obvious things like DNR, do not intubate, when people are clear, or probably would not have wanted to be resuscitated into a state that is even worse than they would have been in before that arrest happened. The question of sort of what is the harm that can happen as people sort of cycle in and out of the ER every time they bump their head, and just talking about the caring of comfort-oriented care, and the question of sort of where do antibiotics fit into that sort of care plan, in that yes, maybe sometimes people may be made more comfortable by being given antibiotics, but the majority of the time the side effects of the antibiotic and the other ways that we have of keeping people comfortable that may be more appropriate than antibiotics. All right, so what can we do now to face the challenge of dementia? Absolutely, engaging, learning, and training is really the key of where it's at. The nihilism of, well, we don't have a disease-modifying agent, and this is a hard and yucky conversation diagnosis to make, I'm going to kind of ignore it, is not okay. That, right now, we've got to stop averting our gaze. When warning signs appear, we've got to work them up. We've got to learn how to explain the diagnosis to patients and families, which is hard but necessary. And I can tell you that the more times you do it, the easier it gets. That the very first time you do it, it's excruciating and hard, and it never gets easy, but it definitely gets easier. The accessing resources like Momentia, engaging people with music and exercise is absolutely useful and important. Engaging families to help plan finances and retirement from driving with gentle advanced care planning. But really, the acceptance and caring is really where it's at. So if you want to ask me, what do I think needs to happen at a system-wide level to improve dementia care, the central core is clinical time and clinic space. That these conversations are hard, they're time-consuming, and they often require more than just you and a patient and one family member in the room. This is a family conference situation that can take an hour. And so the idea that we can do that in primary care is absolutely crucial and important, that we need rooms for family conferences and a much more accessible way to say, I need to see you back in a month and we're going to spend an hour talking about this diagnosis. Dementia-specific advanced directives offered to everyone over age 65, trained social workers to go into the home to teach non-pharmacologic behavioral approaches as part of a Medicare paid home health benefit. And then home-based palliative care, absolutely crucial. Like I said, it can be years before a patient qualifies for the hospice benefit under Medicare. when they still would generally want palliative comfort-related care only, that is really hard to implement without, a trained, wonderful group like a hospice group. And so, but we can do this. we should do this. I just want to thank, so many people have helped me with this work over the past few years. Randy Curtis, who's ending his sabbatical in France soon, I hope. But he has, he has been absolutely crucial, and just many other people on this list here who have provided tremendous input and help to make this, help get this work off the ground. And so let's talk about dementia.